Okay,
Okay.
excellent. We'll begin. Our colleague is going to be joining shortly. Everyone, welcome to an exciting roundtable. I'll just say good day because we're all calling in from different time zones. This is about urban health in India, specifically the SAMAGRA project, and you'll hear more about it when Dr. Rakesh, who is the leader of this project, makes his presentation. The exciting thing about SAMAGRA for urban health in India and urban health in general globally is that this project embodies all the aspects of the issues related to the health of urban poor populations. And so we in the field are excited about this project and looking to this project to help us sift out a number of the challenges and the opportunities in the area of urban health. So without further ado, I'd like to introduce Dr. Rakesh Kumar, who is the leader of this SAMAGRA project. He's a chief advisor to the entire, all the entities involved. This is a USAID funded project, which is also very exciting. And it's also managed by a global entity called Population Service International, PSI. So Dr. Rakesh, I will also ask each of the panelists to briefly introduce themselves, say a quick 1 minute about who they are and why they are. And I'll ask you all, the participants, to hold questions until the end. If there's a pause, I will pull out a few questions. Nonetheless, in the meantime, as you think of questions, please put it in the chat, and I will do my best to monitor and have your questions answered. So without further ado, Dr. Rakesh Kumar.
Yeah, so good morning, good afternoon, and good evening to all the friends and colleagues. And thanks a lot, Dr. Yonit, especially for organizing this particular special session on SAMAGRA. My name is Dr. Rakesh Kumar. My background is in government. I have served in the government of India in various capacities, starting from the grassroots to the policy level for close to, let us say, 25 years. And then I've also served in United Nations Chief Advisor to UNDP for close to 6 years. Currently, I'm Chief Advisor and the Chief of Party for the SAMAGRA project. And I have my colleagues who will be also presenting, in parts, the SAMAGRA components. Over to you, Sainath, for your brief introduction, and then I think we can go. Or should we start with the presentation, Dr. Yonit? No, you are on mute. You are mute.
Gautam has joined, sir.
Start with the presentation, and we'll ask the panelists to introduce themselves as they present. Thank you.
Okay. Can Abhijit, can you present it?
You can share your screen.
Just a sec.
Sir, I can't share. I'm not the host at the moment.
Okay. So
Can do it, I think.
Okay. Try again.
Just a sec. Let me just
try again.
I'm coming. Okay. Yeah.
There you go. Brilliant. Excellent.
Okay, so friends, I'm joined by my colleagues who are helping and supporting, and who are the pillars of SAMAGRA implementation team, and also.
Is this your family?
Yeah, this is our this is our SAMAGRA family. But so when we so I'm going to present this innovative, I would say, solution to primary healthcare and for the urban poor in the country. It's the name SAMAGRA suggests, as the name suggests, SAMAGRA is a Hindi word, but SAMAGRA means holistic. So it's a holistic approach to primary healthcare in India, especially for the urban poor. It's funded
Is this
by
a solution to COVID?
Please do not interrupt. Please have your questions at the end. Thank you. Go ahead, Dr.
Thank you. Thank you. So this project was conceived, jointly by USAID and PSI, in 2019, and then finally it was signed and funded by USAID in April 2020. So it's basically, we started this initiative in 5 cities, and we are going to expand it further to 50 cities. So this PowerPoint presentation I've divided into 3 parts. The first is the kind of the trends of urbanization and the sort of frequency situational analysis. The second component is about the SAMAGRA project as such, mostly the contours, and the third one is the kind of a recommendation which we have. But as I said, my colleagues who are part of this initiative are going to present, SAMAGRA in further details. So when we talk about trends, about urbanization trends, then certainly when we look at the global sort of urbanization, the 50% mark was achieved, the average in 2010. And currently the global, I would say, urbanization is close to 55% in 2018. But when we talk about India, then India is certainly, the urbanization trends are, I would say, as good as the world. Currently, if you look at our urbanization in the country, then we are close to 38 to 40% or so, because India, when we started, let us say, post-independence, our rural population used to be close to 70%, rather more than that. But as on date is close to 40% urban population. But when we put India, China, and Nigeria together, 35, they are going to contribute to 35% of the total global urban population growth between 2018 and 2050. India is likely to touch the 50% mark by 2046. But when you look at the contribution to GDP, I think it's urban, contributes very high to the GDP. And India, it's close to 63% right now, but it's going to be close to 75% by 2030 or so. 7 cities, in India right now, they have a population of more than 10 million, and 71 cities, in 2030, they are going to contribute to close to 50% of the urban population in India. When we divide the urban challenges, then obviously we thought that let us divide into 3, thematic areas. One is the health systems sort of challenges, then social determinants, and then urban governance, because governance becomes absolutely important. So under health system, we all know that it's a triple threat of the diseases which are currently India is facing, with the talking about communicable diseases, non-communicable diseases, and reproductive, maternal, newborn, child health issues. Then obviously in urban areas, we have multiplicity of service providers. There's a poor demand and obviously poor access to the services, especially in the public sector. We have huge private sector presence in urban areas. There's a high out-of-pocket spending, and the referral systems are very poor. Data, obviously, I think it speaks volumes about I would say, the poor data systems in the country. The second, I would say, is the social determinants, the challenges. Obviously, we talk about inequities in urban areas, and especially for the urban poor. I think I need not really mention more about this, but gender-based violence is also quite high. Then, when we look at the clean drinking water and poor sanitation, I think availability is quite poor, especially for the urban poor. Poor nutritional status, indoor and outdoor pollution is also quite high. Job insecurities and poor access to quality of education, especially in the public sector. But I think one important component that is here, urban governance, is at times, most of the times when we talk about public health or urban health, we tend to miss out on the urban governance. And this is, I would say, an important area where the systems of governance in urban areas are quite complex. If I start talking about this, then I think it might take longer. But, there's a duplicity. I would say there are at times multiple agencies working, different departments in the government, they are working just to handle the health systems in these cities. Convergence platforms are very weak and unplanned expenses with the cities. In one of the meetings, I'd gone to Beijing and to attend there. I was one of the speakers along with Professor Jeffrey SACS in 2018 in Beijing, and on the planning commission. When I spoke with him on the sidelines of the meeting, he was very particular about one thing. And because you all know, Professor Jeffrey SACS is also an advisor to the United Nations Secretary General on SDGs, previously MDGs, now SDGs. So 3, I would say, the the three dimensions which rather he suggested, as you all know, is the social inclusion, economic growth, and environmental sustainability. So it's called as the triple bottom line approach. But the fourth dimension, which he really highlighted, was the governance. He said you can't achieve these three dimensions without having a sort of robust governance and a clean governance, in the helm of affairs. When we talk about India, especially, India is a story of numbers. We are a population of 1.4 billion with 26 million birth cohort. We lose close to 1 million under 5 children, close to 25,000 mothers because of complications due to pregnancies. So anything India contributes, to the global burden in any disease or anything is anything between 15% to 25% or so. And at times it is more than that. But India is also a success story in making, I would like to mention, and very rightly so also, because when we look at the kind of achievements which we have made since 1990, our under 5 mortality used to be as high as 126 per 1,000 live births, which has now come down to 34. You look at maternal mortality ratio, it used to be 556 per 100,000 live births, which has now come down to 113. But still, we are losing 25,000 mothers. It's not a small number. And I would like to say that why even a single mother should die because of complications. And she gives us a notice of 9 months. So I think that becomes important. We eradicated polio in 2014. We achieved maternal newborn tetanus elimination in 2015. That was before the time or the target date which WHO had fixed for us. We have introduced Mission Indradhanush, electronic vaccine intelligence network. So there are so many high impact interventions India has taken steps forward. But I said still, I think there's a lot to do. But when you talk about urban, especially the urban poor, then under reproductive health, I think the data speaks volumes about it. Close to 24% urban poor, they are the teenage pregnancies which we have in the urban poor. And teenage pregnancies, the chances of maternal mortality is almost 5 times in teenage pregnancies than the normal pregnancies. Similarly, you look at the anemia levels, I think across I would say India, the anemia levels are quite high, anything between 53, 54, 55%, close to 60%, especially during adolescent period. Look at access to modern contraceptives is close to 50%. TB prevalence is double in urban poor as compared to urban non-poor. Gender-based violence is close to 39-40%, again very high. Access to clean water is also very low. I would say it's just 38%. And household kind of open defecation is also quite high. That is 25%. COVID has impacted very adversely, and especially if you look at it's a dual crisis. I always say it's economic and health. We have lost close to 230 million jobs, and also so there is a loss of lives and livelihoods both. We have lost close to 4.4 million people in the country due to COVID, and the numbers are also quite high. Especially April and May has been quite, I would say, dreadful for us, and I would call that as kind of epicenter of COVID in the world. And obviously, urban India has been most hit by COVID-19. Lockdowns have further impacted, especially on the non-COVID patients who suffered the most. Look at the rising non-communicable diseases, communicable diseases, and TB also, because they could not even have access to the treatment. Reproductive and maternal and newborn child health again impacted very badly. The routine immunization coverage has slipped down like anything. Mental health issues, including the healthcare viewers. Morbidity and mortality due to non-COVID cases have also increased. When we talk about, because it has impacted adversely again the universal health coverage. Insufficient funds now because during COVID times, the GDP has again slipped down. So where do we are going to have more funds for universal health coverage? High out-of-pocket expenditure, poor access, everything as well. But we see a sort of silver lining too, and the COVID has drawn attention for improved investment in speeding up the urban health, universal health care, especially in the urban areas. So when we talk about SAMAGRA, this is the second part of my slide. So SAMAGRA, as I said, was conceived as an innovative solution to primary health care, especially for the urban poor, and with the 5 objectives primarily. I mean, how best we can provide and improve access to affordable quality primary healthcare services to the urban poor. How best we can improve the urban governance, addresses the barriers of social determinants of the health. reduce out-of-pocket spending and financial risk protection, and promote gender equality. So I would like to say that it's mostly like achieving universal health coverage, that is SDG target 3.8. When we talk about the SAMAGRA framework, then I mentioned about the challenges. Challenges were divided into three components: health system strengthening, social determinants, and urban governance. So similarly, we are trying to address those challenges, under these three pillars of health system strengthening, social determinants, and urban governance. I'm not going to go into the further details. So we adopted, 11, I would say, strategies and approaches. So we are fully aligned with the national, state, and the local governments and their priorities. Similarly, also, we are aligned to the global agenda. Partnerships is I would say, is the hallmark of this particular project. We have partnered with so many, I would say, development partners and agencies. I'm going to talk about a bit more about this. We are trying to harness the presence of community-based organizations and NGOs, because in urban areas, we have them in numbers and in abundance. Private sector, as I said, this is also one of the strengths in urban areas. They are not really available in the rural areas. So how best we can engage private sector in providing at least the primary healthcare services. Innovations is the heart and soul of this project, and Suma is going to talk more about this. But we are going to develop those kind of innovative, integrated, solutions to the primary healthcare. We have created something called as activity metrics of 100 activities. Social and behavior change communication, I think anywhere you talk, it is going to be an important factor. The demand side, over demand in the urban areas becomes important. And when we talk about this, I'll cite one example in my next slide. Inequity is also one of the major issues, as I mentioned in my previous slide. So that is also going to be one of the areas of strategic approaches. Ultimately, we are going to work beyond the health sector, with system strengthening. So that's why how best we can achieve, let us say, urban resilience, by improving the health systems and beyond. And data, of course, I always say in government, especially India, data you'll find always quite spurious. Especially, data, because urban averages, they mask the urban poor data. So we are going to focus more on data, research, and monitoring tools. These are the three, I would say, implementing, sort of pillars you can call, or anything you want to say. But again, implementation strategy is also, it is three components. First is incubation. So we are going to incubate and source sort of newer ideas. So it's the innovations which, is being led by Suma and a strong team supporting her. Then how best we can accelerate these innovations, or how can we scale up these innovations and some ideas. As I said, again, it is going to be an integrated approach, integrated solution. And third is the technical assistance. Dr. Ajit is here to talk about this today briefly. So how best we can provide technical assistance to the government and other municipal corporations, especially to make those available health policies and programs implementable. One of the highlights of this particular project, and I'm happy to share with you, and we are really proud of this, that we have created something called a program advisory group of experts, and there are 16 thematic subcommittees called as SAMAGRA advisory committees. Dr. Yonat happens to be, and we are fortunate to have her as a co-chair for the program advisory group, which is at the national level, and the 16 thematic subcommittees of various themes, like whether we are talking about reproductive health, maternal health, child health, nutrition, health financing, urban planning. So that way we have 16 SAMAGRA advisory committees. Dr. A.K. Nandakumar, who has been previously the chief economist of USAID and currently advisor at USAID, is the chair, and Dr. Yonat, as I said, we are proud to have both of them as our chair and co-chair. And it has close to 150 national and international experts, participating in different subcommittees. Behavior change communication and social, mobilization becomes very important, especially for the demand side. And we have put behavior change communication in the center stage. I just want to mention one thing. When we started looking at, when we eradicated polio, and when we, let us say, eliminated maternal newborn tetanus, we started looking at our routine immunization data. And we looked at the data we interviewed, WHO interviewed close to 100,000 parents of children who did not receive routine immunization. And you'd be surprised that 33% of the parents knew nothing about the vaccines. Another 30% of the parents only knew about the AE files and side effects, meaning thereby 63% of the parents either knew nothing or they only knew about the side effects. That's why when we looked at Mission Rainbow, Mission Indradhanush, which is also one of the global best practices in routine immunization, we brought in a sharper focus, and rather I would say that was in the center stage. Behavior change communication was in the center stage. So we have these interpersonal communications working very well for the slum beneficiaries. We have created champions who are going to talk, who are talking to the people in urban slums. Street theater, etc. Creative means people are being engaged. Virtual group meeting because of the COVID and lockdown we had during the COVID. We have created IC materials, which are again quite innovative. We have also cascaded down the government endorsed communication material because the communication has to be single and straight and a very simple one. So government communications, we are trying to take them down the line to the communities. We download shared videos and testimonials and published opinion articles also. When I talked about the partnership, as I said, the USAID is our funder and the topmost partner. We have aligned and we have partnered with different governments, whether it is the NITI Aayog or the government of India or the state governments, development agencies, UNICEF, WHO, ADB, Gates Foundation, Rockefeller, academia, yes, to quite an extent. And obviously we have 10 implementing partners who are helping and supporting us in implementing this project. In conclusion, I would like to this is my last slide. Urban health is central to achieving global goals. I think there's no second opinion about this. We need to focus on comprehensive primary health care because it is a precursor to achieving universal health coverage. That is target number 3.8. SAMAGRA is a template for achieving urban health the universal health coverage and SDGs in urban areas. Investment in the health for the migrant youth becomes very critical because India is currently going through the demographic dividend phase, which countries like Japan had in 1964, China in 1978. Similarly, we talk about South Korea and other countries. So India is currently going through this demographic dividend phase, and that started in 2018 until 2055. So next 34 years are going to be very critical for us. So unless we invest in health, education skills, we are not going to really reap the fruits of this demographic dividend. It may be a disaster. And because the youth is migrating to urban areas, therefore it becomes very important for us to invest more in urban health systems. Equity and quality of healthcare, again, is very important, I think, issue in urban areas. So we need to focus on priority basis. We need to leverage private sector NGOs because they have a huge presence. And as the last but not the least, I would like to say that, forging partnership including academia becomes very important. So we are reaching out to different institutes of national and international eminence to partner with on this particular agenda, which is very close to us. So thank you so much for your patient hearing, and I'm happy to take your questions now or later. Over to you, Dr. Yonet.
Thank you, Dr. Rakesh. A really comprehensive and amazing presentation, giving us a sense of the significance and the comprehensiveness of this endeavor. Thank you. So I would like to remind the audience to note your questions in the chat, and we'll go through to the next presentation for coherence, and then we'll have major questions at the end. That said, I'd like to invite Dr. Ajit Sudke to the lead technical person for the SAMAGRA Hub. And Dr. Ajit, you will tell us about the City to City Learning Platform initiative related to COVID-19. Thank you.
Yeah, thanks. Thank you, Dr. Yonet. So, can somebody share the screen?
Okay, I think you have access to share, Dr. Ajit. Here we go. Let's go. Do you have it now?
Oh, just a second.
Okay. So while we're waiting for Dr. Ajit's slides to come up, does anyone have a particular question? There you are. We'll hold that question for later. Thank you. Go ahead, Dr. Ajit.
Ajit sir, I'm sharing Abhijit this time.
Okay, yeah. Thanks, Abhijit. Can you go to the presentation mode, please?
Excellent.
Yeah, so So as Dr. Rakesh just described, the SAMAGRA project is holistically looking at strengthening the entire urban health ecosystem. And thanks to USAID, and Gautam is on this call here, who's the AOR for this grant as well. We received an additional grant to actually build a city-to-city COVID-19 vaccination learning exchange platform, which would really help cities to come together and learn and share and learn from each other. And so I'll briefly take you through what exactly we're trying to do under it. So this is a small grant for a 1-year period. It ends in April next year. So next slide, please. Yeah, so as we all know, COVID-19 vaccination remains the key intervention to control this pandemic. And while we say this, it's also critically important that people continue to follow COVID appropriate behaviors. Also, you all are aware that India played a very critical role in supplying vaccines to around 95 countries under the Vaccine Maitri initiative. PSI, with the support of partners, aim to build this global vaccination knowledge management system with a focus on the global south. Under the initiative, we are planning to have this web-based interactive learning exchange where we would have five Indian cities matched with 10 cities in Asia, from Asia and Africa. And as I mentioned, this project duration is just for a year. Next slide. So what we are focusing on is to engage with various stakeholders, which would include public, private sector, donors, as well as academia, and curate evidences around COVID vaccination, which have really impacted the delivery of vaccines or the vaccination as such. Create knowledge tools and products around COVID vaccination, which should then be disseminated through this learning and sharing using this platform. And so the key results area would be developing these knowledge products in the form of case studies, video stories, training materials, planning and monitoring tools. The digital repository of this products could be used by various stakeholders. And throughout this remaining 10 months of the project period, we would be having these interactive workshops and webinars happening with these cities. Next. Can we move to the next slide?
I think there is a lag. I've already moved to the map slide.
Okay. It's coming.
Okay, I think there's a. Can you hear me? There's a delay from my side.
Yes, it's coming.
Ajit, we can hear you. Please go
We
ahead.
can hear you. Yes.
Right. Thank you. Yeah. So. So what we have done is that we've identified these cities using criteria which included demographic indicators like population density, the literacy rate, GDP per capita. And what we also saw was presence of PSI as well as USAID in these countries, and the rollout of the vaccines in the respective countries. What we have tried to do is match one Indian city with one city from the African continent and one from Asia. However, you'll find that for one city, given that there are 6 cities in the African continent and 4 in Asia, we had to match one city with 2 cities in Africa. So Ahmedabad was matched. Ahmedabad had both cities from Africa matched with it. So Addis Ababa and Abuja. So the idea of creating these pods is that these cities would regularly interact with each other on a quarterly basis, and all the 15 cities would come together at least twice during this particular project period. Next, Abhijit. So what we are trying to do is to, you can click on the, So what we are also trying to do is track these 3 critical indicators for COVID vaccination. where this first indicator is around the share of people who have received at least one dose of COVID-19 vaccine. And thanks to our World in Data, where this is available to everybody. So what we find is that Cambodia has really done quite well amongst these 10 countries. And if you see here, we've tried to get this data till July of 17. And Cambodia has actually gone pretty ahead, nearing 40%, whereas India is around 24% on this indicator. The next slide is the other important indicator which we are trying to track, which talks about fully vaccinated, the share of population which is fully vaccinated against COVID. And from our immunization strategy, as you all are aware, like we track full immunization, I think for complete protection, it is really important that people are fully vaccinated against COVID, and majority of the vaccines available today need 2 doses which need to be given. And so here again, I think Cambodia amongst these 11 countries has done really well when it comes to fully vaccinating the population, while all the other countries, including India, are hovering around the 5% mark. So a lot of efforts really needs to go in here as well, and a lot of planning would also be required on how exactly we are able to achieve this. Next, Abhijit. So this is another indicator which we are tracking, which talks about per 100 people how many daily vaccine doses have been administered. And so here again, what we find is that different countries are at different stages of vaccine administration. And once again, Cambodia is leading from the front. And again, here we find that majority of the countries in this share per 100 people are also really not doing that well. And so a lot of efforts also needs to go in here. Next, Abhijit. So what we have tried to do in this slide is really look at all the countries together on in terms of the doses administered in millions, the weeks since the vaccine launch, and the number of doses administered per 100 persons. So here we find that while in terms of absolute numbers, India, which has achieved more than 400 million doses of COVID vaccination, when it comes to doses administered per 100 persons, it's Cambodia at 59. And India is at 29, and the only other country in 2 digits is Nepal, around 14. But all the other countries, as you see here, are in single digits. And on the x-axis, you have the weeks since the launch of the vaccine. And so despite having launched the vaccine, after India, in terms of doses administered per 100 persons, Cambodia is leading. But we need to really look at, like, if we really think of the denominators, given the size of India, I think what India has tried to achieve since the launch of the vaccination is unprecedented. And we are really looking forward to ensure that majority of the population gets vaccinated by the end of this year. Next, Abhijit. So since this is an urban health focused, and like we are really looking at cities, so thanks to the CoWIN platform developed in India by the Ministry of Health and Family Welfare. So this dashboard, CoWIN dashboard, helps us to really look at district and city-wise indicators as well. So here we have tried to look at how the 5 Indian cities have been performing when it comes to COVID vaccination. So on the x-axis here, we have percentage of population fully vaccinated. On the y-axis, we have the at least 1 dose administered, and the size of the bubble gives you doses administered per 100 persons. So here again, what you find is that the 3 mega cities, that is Mumbai, Delhi, and Ahmedabad, are hovering around the 50% mark. So that is the doses of administered per 100 persons are around 50 per 100. Whereas if you look at Khorda, it is around 78, and Indore is 72.2. But if you look at fully vaccinated population, I think Khorda, which is Bhubaneswar on the eastern part of India, Odisha, has really done very well in terms of fully vaccinating their people. It is around 26%. And following that is again Indore. While all others are around 11 to 12% of fully vaccinated people, and India is around 6%. So this actually gives us a landscape of how different each city is also conducting the vaccination campaign. And the idea of sharing this slide was also to just bring forth this, that there are so many good things or innovations or practices that cities can actually share with each other and learn from each other. Next slide, please, Abhijit. Yeah, so what we have done is that we've identified these 10 key themes for COVID vaccination, where we think that different cities and countries would be able to share their challenges as well as their best practices. So starting from vaccine development, the manufacturing, procurement, we all know that India is called the pharmacy hub of the country and of the world. And we have one vaccine which is completely India made, which is Covaxin by Bharat Biotech, and we have Serum Institute of India, which has helped develop the other vaccine. And we've also recently imported the vaccine from Russia, which is now being given in India as well. And in the coming months, we are going to add some more vaccines as well to this basket of vaccines. So this really becomes critical as to how do countries or cities really ensure that they have adequate vaccines procured for their populations. Then digital innovations really becomes critical. And here again, thanks to our Honorable Prime Minister, just a week back, he announced that the CoWIN application, which I was just talking to you about, is free for all countries to actually use it. And it's an amazing application which really helps in people to register and get their vaccines. And it also helps in understanding for the policymakers as well on how exactly to plan and all that. So this is just one innovation. There could be multiple other innovations which are happening in India and outside as well, which could be shared on this particular platform. Also, vaccine supply chain remains critical, given that you really need to ensure that vaccines are effective. The cold chain needs to be very well maintained. And some vaccines like Moderna, which is yet to come in India, like they require really a very strong negative temperatures to ensure that the vaccine remains potent. Also, the demand side, as we all know, there's a lot of vaccine hesitancy there across multiple countries. So communication, social mobilization is really critical. And there are some very innovative things happening in cities as well as in countries to address this particular challenge. Also, AEFI, I think India has been really fortunate and has really ensured that adverse events following immunization are minimal, and whatever happen are addressed properly. So this again is a very important area where we can have multiple good practices being shared. And then the other 5 areas around governance, planning, management, capacity building of the frontline workers, the ANMs and the nurses administering the vaccines, as well as of the ASHAs who are promoting people to come forward for vaccination. This entire capacity building exercise really becomes important. Private sector has played a crucial role in India, and so how are other countries engaging with the private sector? This would really be interesting to understand and share with everybody. And finally, monitoring supervision, like in routine immunization, also becomes critical for COVID vaccination. So these are the 10 thematic areas which we have identified. Next, Abhijit. So these are the critical stakeholders. So PSI is the manager for this city-to-city COVALEX initiative. We have USAID, who's not only a donor but also guiding us and providing us the necessary input on how best to take this forward. Without the government's participation, I don't think any program can actually be successful, given that the government is spearheading this entire initiative. And so we have the Ministry of Health and Family Welfare, Government of India on board, and they have identified their POCs as well, and would be sharing the different initiatives undertaken by the government on this particular platform. So a lot of things to learn from the national and the state as well as the local level government people as well. And we have our partners who are actively supporting us in this, the World Health Organization, UNICEF, PATH. We have the Gates Foundation as an advisor on our committee on vaccines as well. And this team of partners is actually helping us to take this initiative forwards. And we have our team in SAMAGRA, who's actually managing this entire platform at the national level and coordinating with all these partners as well as the ministry. Next slide, Abhijit. Yeah, so till now what we've been able to do is that we would be soon having the project team on board. We have oriented our implementation partners, as Dr. Rakesh mentioned in his presentation, that we have around 9 implementation partners in the field supporting under SAMAGRA, and COVID vaccination is an important area of their work as well. So we have oriented them on what exactly we are expecting out of this particular initiative, and they are more than happy to be to share their learnings from the COVID vaccination support which they are giving to the local governments. Also, we would soon be having our partners on board for doing research as well as communications. And with them, we would start the primary research for COVID vaccination in India as well as in a couple of cities outside of India as well. In partnerships, I've already mentioned these are our partners in India, and also outside India, we're really looking at PSI is helping us in 9 of the 10 countries, and we have PATH, which has connected us with these 4 country offices in Vietnam, Uganda, Kenya. USAID India helped us to connect with the USAID missions in these different countries. We also have local NGOs like Eminence in Bangladesh, who's agreed to support us in this particular initiative. Next. And so this is the final slide. So, so as I mentioned, we would be starting with the city level rapid assessments to understand what's happening on the COVID vaccination through primary and secondary data collection across the 5 Indian cities and also cities outside of India as well. We would be developing the city profiles and start documenting the good practices. We are planning to initiate the learning sessions between the pods, as I just mentioned, the 3 cities coming together. So we are planning to have this, the first session sometime next week for Dhaka, Mumbai and Cambodia. And then we would also have a separate a session on the private sector engagement on COVID vaccinations as well. In the next couple of months, we would be developing this web-based platform as well, which would be used to collate all this, the knowledge material over there to be shared widely. And towards the end of the project, we would be having a global learning event, which would be organized. We are thinking of having it in person, but if conditions permit, otherwise we would have a virtual event to disseminate the learnings from this particular initiative. Next, Abhijit. Yeah, so that is all from my side. Thank you so much, Dr. Yonet, for giving us this opportunity.
Excellent. Thank you, Dr. Ajit. We look forward to this important learning platform opportunity, and we'll stay tuned. Thank you so much. Our next presenter, we'll go right into the next presentations. Thank you for putting your questions in the chat, and I see an active responding going on, so please keep it up. Our next presenter is Ms. Suma Pati. Suma leads the Innovation Hub of SAMAGRA, and Suma will tell us about the innovations and knowledge management process there. Thank you, Suma.
Thank you. Can you hear me?
Yes, very well.
Okay, great. I'm Suma. I have my experience ranges from public health, but public health with private sector involvement, with experience, in creating and designing innovations in public-private partnerships, in models that could, be commercially viable and sustainable, and, across both rural and urban contexts in India. So I will very quickly take you through, what is the approach? Why do we have an innovations hub in SAMAGRA, in the urban health project in SAMAGRA? What is our approach towards these innovations, and what specifically are our plans under the innovations? One second, let me just get it into the slide. So in terms of, just to start off, why do we have innovations, given that, there are tried and tested models, approaches, practices that we've known have worked. Can't we then, just replicate those innovations into urban health? Not really, given that the context of an urban, demography and the context of an urban household and network even, provider, supplier, and community network differs from where we, achieved success so far in the rural context. So to translate those ideas into an urban context as is going to be, challenging in terms of how do we get to the outcomes. And therefore, we're looking at addressing those gaps, under SAMAGRA, addressing those specific demand and supply side gaps, and looking at ways of engaging with and building a bridge, between the community and the government, the systems, not just, confining ourselves to public health, with an understanding that health is one of the many priorities of an urban, audience, an urban poor audience, and that, the other sort of umbrellas need to be, or the structures need to be fixed or facilitated. We're looking at health in that context being a central piece, but only one piece of the, other elements and social determinants, of arriving and achieving those health outcomes, arriving to and achieving those at those health outcomes. In terms of the guiding principles, we're looking at innovations that are user-centric, not top-down, but come from the community, are articulated by the community as a need that they are looking at addressing, are gender sensitive. So this runs through the project as such, but specifically in with respect to innovations, we're looking at actively ensuring that innovations that we look at are gender equitable and actually addressing women as a key audience. We're looking at innovations that are fit for scale. When we say fit for scale, we're looking at ideas and models that in some way leverage existing systems and therefore can be quickly scaled up, rather than something that requires great investment in implementing, running, and scaling up. And when we say leveraging resources, we're looking at both the private and the public sector in terms of that leverage. We're looking at implementation ready innovation. Here what we mean is that there are multiple innovations and there are grand challenges, etc., that bring about interesting innovative ideas at the concept stage that need to be proved, so small pilots. And then we look at a very few innovations that go up to scale. What is missing is the missing middle in the sense that transferring these contexts, these ideas and these concepts to scale is a gap or is a bridge that most innovators find difficult to traverse, and that is the missing middle that we are looking at. So we're looking at innovations that have some preliminary evidence, not necessarily in the urban space, but some other context maybe, and then we're looking at tweaking those innovations to address the urban audience, urban context, and also looking at giving them the systems and equipping them so that these innovators get to scale. I've covered this. So again, the type of innovations we're looking at fintech solutions for urban health, especially to reduce out-of-pocket expenditure in primary care. We're looking at a variety of supply-side innovations, possibly supported, to improve delivery, and possibly supported by technology. We're looking at, in some way, addressing, social determinants of health, whether they be gender, nutrition, or even, accessing entitlements available provided by the government. In terms of demand side solutions, we are looking at solutions that drive community participation, not just in seeking healthcare, but in seeking accountability from healthcare, whether in the public or the private sector. This is very, this just gives a sense of what is it that we're looking at. And like I said, since these are user-centric innovations that we are planning to roll out, these are our ideas which will be refined and, built based on what we hear on the ground. So broadly, we're looking at, facilitating government linkages, like I said, reducing out-of-pocket expenditure in primary care. We're looking at improving, bringing in social entrepreneurship models and community-based entrepreneurship models for improving menstrual hygiene, both in terms of products and information. We're looking at bringing in health technologies in maternal care, TB, etc., promoting gender equity, reducing malnutrition, and maybe looking at a combination of both, through focusing on adolescent girls and their nutrition, because the recent NFHS data that came out for a few states in India actually showed that we have deteriorated when it comes to status of girls, malnutrition for children, also for women and young girls. In terms of the pathway, again, I'm not going to spend too much time here, but the process is to select. The selection involves, also feedback from community, which, we've just written the, or inputs from community. Then we have a validation phase. Given that these innovations have already been tested for proof of concept, the validation is essentially refining the innovations for about 6 months, getting user feedback, making those relevant changes to address the problem at hand, and then modifying it for an accelerated phase, which typically in our the first 2 innovations, and hopefully in the future as well, we'll be looking to cover a city or 2 where SAMAGRA is operating, and then we have the scale-up phase, which is essentially facilitation of scale-up, not really actual scale-up. Where again the results based on again we have this monitor, evaluate, and disseminate. So monitoring and evaluation will be robust and carried out through the process, all of these phases, and based on those that data, we will be facilitating the innovators to scale scale or replicate to different geographies or geographies within the same state. I will now quickly take you through the 2 innovations that we are planning to roll out in the next couple of weeks, or in one case weeks, and in the other maybe a month or 2. So giving you a context of why are we looking at facilitating linkages to the urban, to government. Why are we looking at creating a bridge between the urban poor and the government schemes and benefits and entitlements? Again, like I said, the urban context in most countries, including in India, is such that it is dominated by people who have roots elsewhere. They're migrants, they've moved, they keep moving. What then happens is that these groups have lack of documentation or incomplete, insufficient documentation. What that means then is that then they are unable to access entitlements that are due. So we're not talking about creating something new. We're looking at ensuring that what is available is something that should be accessed by people, including migrants who come to the urban space. And so we've actually brought on board an innovator that does exactly that, where there are people from the community recruited as entrepreneurs to map eligibility of various schemes for each household, and then to pursue those schemes and entitlements so that they are availed by the target user. This we think is going to be a game changer, because what this does essentially is actually institutionalizes, makes more transparent, and makes more efficient a system that already is existing in bits and pieces in an informal manner. So typically in India, there is this sort of a middleman, a middle woman, a middle person who's getting paid to help urban households or any households to access these schemes for a fee. Now, the fee is unregulated. There is no transparency, and there is no assurance of actually getting the entitlement. Here, we're trying to make this more systematic. Of course, as I said, the key aspect in any innovation under SAMAGRA is going to be evaluation and monitoring and an assessment of an impact. So the end of 2 years, when this is rolled out and implemented, we would like to see, and hopefully we will see results that that are positive and then can be scaled up and replicated elsewhere. The other thing we're looking at and that we should be rolling out shortly is so the context is that 70% of healthcare expenditure in India, and that has really not changed over the last last 70 years. So 70% of expenditure on healthcare by Indians across the board is out of pocket. There have been changes made in the last maybe 20 years that have brought in private insurance companies, that has the government supports, or a very small group of population that as part of the government service, which in India is comparatively a public sort of government staff versus functionaries compared to any other country in India is pretty low. So the coverage of insurance has been and continues to be low. There is a new government scheme that looks at supporting secondary and tertiary coverage. What is missing, however, is coverage for primary care. So there is the public sector. However, for a lot of, for example, for contraceptives, short-term methods, 70% of access among the urban poor as well is from the private sector. Now, an injectable every 3 months, an IUCD is expensive and not covered under any kind of insurance. TB care is a prolonged care over, spread over, depending on the type of TB, 6 to 12 months. Again, because it is not a hospitalization related expense, it is not covered. So how do we get the urban poor to reduce their expenditure for seeking preventive and curative treatment for such conditions is something that we are looking at. We're looking at accessing the market for this. We're looking at community systems as well, but so far we've really not found models that are, so we'd like to explore more. However, right now we're looking at an angle that leverages the market, leverages current insurers, so that we are able to pool risk. And targets the new and upcoming sort of population that Dr. Rakesh talked about, the demographic dividend. So we're looking at youth, we're looking at the 18 to 50. I mean, we're looking at this age group, and we're seeing how it is difficult for an innovation to solve all the problems, to address the full scope and range of target of the audience that requires support. However, we're looking at one solution that could actually address the concerns of this population. So these are the two ideas that we will be rolling out soon. And that is it from my side. Thank you.
Thank you, Suma. That's brilliant. We're going to be looking forward to hearing more about this and hearing how you engage the various sectors. I see that there's a detailed question for you. So please pay attention to it in the chat, and we can talk more about it at the end. Thank you. So next we go to Dr. Sainath Banerjee, who will talk about the context of urban health in India as it relates to the global context, what that means, and how this all fits. Dr. Sainath?
Thank you, Dr. Unit, and thank you, Manchester University, for giving me this opportunity. Let me share the screen. Abhijit, can you help me to?
Yes, sir. I'll share the screen, sir.
Okay.
So you need to stop share so Abhijit could share. Great.
Okay.
Okay. You got it, Abhijit? There you go. Brilliant.
So very quickly, an introduction from my end. Am I audible?
Yes, you are. You're audible.
Okay. So my name is Dr. Sainath Banerjee. I'm a medical anthropologist having experience in the field of public health over 25 years. And last 20 years, I'm continuously learning and enjoying urban health. Worked at the city level, then moved to the zonal level or the district level, and thereafter worked at the national level. Mostly my experience handling large-scale multi-stakeholders partnership program on urban health with funding by USAID. But other than USAID, also worked with the funding from BMGF, the Gates Foundation, private foundations, and international agencies like ADB, etc. And within the urban health, my interest is planning, community participations, BCC, health system, and identifications of the most vulnerable population. So now coming to this, my presentations, next slide. So in my presentations, it has a kind of, one is Indian experience, and also I'll be talking then some of the global experiences region-wise, Africa, then Latin America, and also Europe. And specifically, I'll be saying the implementation experience from India. So I will start with this photograph, very interesting. And the left-hand side, Chennai Corporation. This is 1688. This is the oldest municipal corporations outside. So, and it was established with the Act of East India Company and Municipal Corporation Act with an objective to collection of tax for the welfare of its citizens. And currently, this particular structure with its staff, and they serve 7.1 million population of Chennai, 200 councillors, 15 zones. Now, if you shift your focus towards the right-hand side, this is the photograph of Mr. Walter Charles Rand, a British civil servant who was appointed in 1896 as a plague commissioner of Pune, and unfortunately used, because that time bubonic plague was, there was a bubonic plague, and so he was commissioned to control it. Unfortunately, he used brutal forces to curb the eventual. Why I'm sharing this particular photographs in institute, that India has a kind of a very long legacy of urban governance, and so focus on how to control, a kind of disease. Next slide. So Dr. Rakesh Kumar in his presentations talked about the third dimension that is important to discuss on regarding the issue of urban. This particular slides is giving and a kind of indication of how India has addressed the issue of urban governance, because urban health is an integral component of urban governance. So 74th Constitutional Amendment was introduced by Government of India to give maximum power to the citizen and the structure at the municipal corporation level, so that they can plan and implement the welfare schemes and activities. Next. So 1992, as I mentioned, the government introduced 74th Constitutional Amendment. This is a basic framework of decentralization of power and authorities. Municipal corporations, they class municipal corporation, municipal councils, and Nagar Panchayat. This broad classification is based on the population size of the city, whereby municipal corporations, big companies like Mumbai, Chennai, Kolkata, all are municipal corporations, and the smaller size cities and very small are governed by Nagar Panchayat. So each municipal corporation has 18 functions, which is a part of 74th Amendment. Public health, sanitation, conservancy, and solid waste management are the part of that. These all activities are time to time, introduced by 69 different municipal acts, and they cover close to 4,000 cities of India. And there are significant differences in terms of size when we talked about Mumbai to compared with the, which is covering 12.5 million population, a kind of country's population, an African small countries like Rwanda. And we have another city, is Gangtok, which is very small. Now, within the municipal governance, the services we are talking about, there are 11 services which are related to health. Now, if you take a closer look, out of 11 services, 4 are construction related, 2 are regulatory kind, 1 is vital record collection, that is birth and death. It's mandated in India, and you have to enroll and register if there is a death or birth in your family. Prevention of epidemic, that's also an important activity. Under service, there are 2 activities. 1 is ambulance service and garbage disposal. So where is health? Health service is only 1, that is public health vaccination. Next. So under this situation, this urban municipal structure, they continuously operate. So it is not their fault that they are not giving a comprehensive primary health care, which we are talking about. So if you see what are the kind of investment has happened from 1994 to 2020, and thanks to different bilateral agencies, unilateral agencies. So the investment first kind of started with World Bank assisted India Population Project 1994. This project was in Bangalore, then Kolkata, Hyderabad, and some other cities. A lot of the 5 years program, experiment out, and there are a lot of lessons, and those lessons transfer to the other program, largely to USAID, continuous investment on urban health. It started with environmental health project, expanded urban health program, urban health initiative, and HU, Health of the Urban Poor program in 2010, which continued till 2015. Now, all these programs were focusing on how to create a buzz among the policymakers and decision makers of the country. So there should be a separate program at the national level on urban health. So this resulted ultimately with introduction of world's largest urban health program, which is National Urban Health Mission. This mission across the country, covering 4,000 cities with complete commitment from the government of India. But USAID's and other donors' commitment continued. So there were a program on USAID sites called PAHAL, then the challenge initiative Healthy Cities, and finally current program that Dr. Rakesh Kumar talked about, SAMAGRA. I'm sorry, I forgot to mention about that Asian Development Bank under not a program, but under soft loan, they invested $300 million in first phase, and in second phase, they have also invested $300 million to Government of India. Next. So the interesting part, this particular slides, there are 9 programs. All the 9 programs are Government of India's programs. And if you see very closely, interestingly, most of the programs started after 2013, that is after NUH. So if you see the program, there are 4 programs which are urban population, that to be urban poor and vulnerable. So what are those? National Urban Livelihood Mission, which talks about how to address it. Then there is an Atal Mission for Rejuvenation and Urban Transformation. This is all about in urban area. Then there is a smart city mission program, which is for Pradhan Mantri Awas Yojana, which is also for the rural and for the urban. So if you see the of engagement or commitment from the government, it's primarily they're not only addressing the health, but also addressing the social determinants of it. Next. So what are the learning? Now I'm focusing on the learnings, and these learnings are primarily from USAID or other donors. And also a kind of learnings from the National Urban Health Mission. So first learning was data for decision making. Dr. Rakesh Kumar and other people mentioned that there is a need for data. And when we talked about data for the urban context, the urban average or urban reach, they always mask the urban poor. So we have to have disaggregated data and region or city specific when we are talking to plan something. Because this is very fluid. If you wanted to do something, some kind of concrete planning for a city, you need to have a clear understanding where are the settlements, what kind of populations, what are their economy and occupations, etc., etc. You need to have an urban health consultation, because understanding what the key constituents and their interplay, how they are connected, that interactions understanding, unless you understand the ecosystem fully, you cannot introduce your solution. And for that, comprehensive health ecosystem analysis is very important, which has three kind of components. One is health vulnerability assessment, health facility assessment, and multi-stakeholder consultation. So first, you want to understand the degree of vulnerability that exists within the urban population or different kind of population. And then understanding the capacity through health facility assessment of the service provider. Because not only the demand side, we have to have what are the kind of, the capacity of the providers. Next. Community should be the center of all planning and intervention, because the problem, it is the community. If we cannot engage the community for a planning, will be, surface. Slum and informal settlement should be the unit of intervention. Partnership and coordination among the multiple stakeholders paramount. Complementing intersectoral convergence essential to address health and health determinants. Ward as an administrative smallest unit should be the center of planning. Next.
Sinus, Dr. Sinus, I think you're frozen. We can't hear you.
Yeah,
Can
we
you-
can't hear him.
I think he lost.
Oh,
Yeah, he's back.
He's back. He's back.
Hello.
Okay, you're back. You're audible.
Okay. So now from India, I'm shifting my focus towards global, and it my kind of level base to give a kind of profile. What is the global scenario in urban health?
Next slide.
Yeah, Africa. So Africa, how the demographic transition is taking place, 60% of population in the continent is expected to living in urban area. Currently, please remember, African continent, the urbanization pace, the least urbanized, but the pace is very high. So we urbanize Africa by 2050 with 30 to 40% children from that. What are the issues? Lack of access of sanitation and drinking safety. So that's the major issue. Now, I read an article whereby the slum near the Nairobi, most of the people, because they don't have access to the toilet, they use plastic polythene bag to dispose of fecal to the open place. 80% of the poorest population forced to defecate to open area. And then there are cities which are prone for flood vulnerability. Then there is an issue of which is a kind of interesting phenomenon called urban sprawl. That means the cities are expanding. They're kind of, phagocytosis process. They're, capturing the agricultural land. So agricultural land became the urbanized. And therefore, the people who are depending on agricultural land, they're not only losing the land, also as a city, probably one day we're going to face the, food crisis. Weak urban governance system is among most of the African countries. Next. So now the Latin American and Caribbean scenario, if you see the, critically, most of their situation is very similar to India or Asian countries. Sanitation, education, employment, health services, all kind of things is very restricted and compromised. There are slums which in Brazil called favela, similar kind of nomenclature exists, Peru and other countries. High degree of malnutrition, especially among the children, pregnant women, and there are growth in mid-sized cities. So the growth without minus plan, incomplete or inequitable access to the quality health services, and mostly along with the tuberculosis, HIV, malaria, all the disease, they are rampant on substance abuse, alcohol, drugs, trafficking, sex-related crimes. Next.
So you have 2 minutes, Dr. Sainath.
So global population, yeah, just last slide. So global populations 80%, 45 countries, 800 cities, no mega cities, incidentally. Population density varies from 400 Netherlands to 13, just 13 Norway. So what are the issues? Most common issues: circulatory disease, cardiovascular disease, cancer, respiratory disease, and external causes of death. The region is, the hallmark is the aging population. And they are literally sitting on the demographic time bomb, because 65 to 80 age group, people will be double. So they will be required more resources, more support and welfare scheme to support that particular kind of population. Because of the use of the different kind of building material, there are incidents of urban heat island. Urban noise, that's also the causing factor for the high blood pressure and related migraine and other issues. Issues related migration, lack of physical financial capacity, urban local body, especially the Eastern European countries, are also hallmark. So these are the kind of scenario in global scenario in 3 different zones. Next. So this is my last slide. I just wanted to quote from Hidden Cities. That's a very well-referred document. The future of our urban world has stabilized. To what extent we will pay the price as opposed to fulfill the promise?
Thank you, Dr. Sainath. Bringing it all around in full context. Brilliant. Thank you. I would like to, I see that we have active Q&As going on in the chat. I love it. And so please keep it up. Now I'd like to transition to Gautam, who is the person who is making all of this happen through USAID. And Gautam, welcome. The SAMAGRA project is such a flagship project for India and for the rest of the world. So please, you have the floor. Tell us how you're making this all happen and what the other investments are.
Sure. Thank you, Dr. Yonet. And I do see that we have around 8 minutes left. So maybe I'll try to compress my presentation as far as possible, because so many things have already been shared by Dr. Sainath, Dr. Rakesh, Suma, and Ajit. Yes. So let me quickly jump into this slide, which basically shows that for USAID, the SAMAGRA program is not the beginning of the urban health understanding, but USAID, as Dr. Sainath has also shown, has been investing on urban health since last 2 decades, almost 20 years. And what we have with Samagra is basically building on to a whole series of learnings that we had, not only just as an USAID, but also with all our partners, including the government. And therefore, this is more like a journey for us. So Samagra is just a next step in this journey. So the journey began, as Dr. Sainath also mentioned, with the urban health, with the environment health program in the early 2000s. And as Dr. Sainath also showed that even after the 74th constitutional amendment in India, which transferred a lot of power related to public health to the third tier of government. So we have the national government, the state government, and the municipal or the local governments, including rural and the municipal governments. So the municipal governments had 11, but as Dr. Sainath very beautifully showed, only just one relates to actually health. The other is basically sanitation, waste disposal, and all those things. So that was the initial understanding that urban health is basically a public health issue, whereas health care is what the state will take care of. So there was this extreme distinction between health care and the public health, which was essentially environmental health. So the entry point into urban health was only through that route. But what we were trying to understand at that point of time is, what is urban health? Is it only environment health, or there is something beyond that? What about comprehensive primary health care? What about the referral system? What about the total markets approach? Because there is the private sector, the public sector, primary health care of government mainly focused on the rural. So what happens in the urban areas? So we were basically trying to understand, and we means USAID along with our partners and also the municipal governments, we were trying to understand what is urban health. So with that, having gained some knowledge, we went into another question of why urban health. Okay, we understood what is urban health, but why urban health? Do we need urban health in India? At that point of time, early 2000, approximately 65% of the population was rural. So why should we even talk about urban health? To really build on a resource to talk about urban health, to find out, is there a need, where there is a need, what specific interventions are needed. So we created some institution called Urban Health Resource Center. And as a resource center, it actually started engaging the government, the civil society, the academia, and everybody to try to understand, do we really need urban health? And having this policy discourse at the central government level, state government level, various bureaucrats, various government programs. So basically, we were trying to explore that, do we really need urban health? By the time we came to 2009 to 2015 timeframe, I think the government of India really understood, along with the state governments, that yes, we do need urban health, but the question was how to implement it. Because as I said very clearly, health care was the domain of the state government, whereas the municipal governments were basically looking at this waste management, sanitation, and the environmental health issues. So how do we implement something which will be implemented by somebody who really doesn't know the urban space? Because when it comes to urban space, there are so many shifting population. We have almost all the cities in India where the daytime population is 1.5 to 2.5 times the nighttime population. So how do these people who come in and go out every day are provided healthcare? They can't be done in the rural areas because they are not there. But urban area, the population census doesn't take care of them. So there are so many challenges. So we were basically trying to explore how to implement urban health, and that is where we had the Health of the Urban Poor program. And if you recall Dr. Sainath's slides presentation, it's around 2013 that the National Urban Health Mission was launched. So with all this of what is urban health, why urban health, and how to implement, we actually had the central government taking the first step in recognizing that yes, we need to do something on urban health and start implementing. So once the implementation started, I think the challenge shift from how to institutionalize this thing. And the moment we talked about institutionalization, we really saw there are two different streams. One is institutionalizing at the city administration level, and the other part was the private market, because we saw that almost like 80% of the healthcare services were being provided by the private sector, whereas the National Urban Health Mission was strengthening that 20% only. And there was just some reference to the private sector, but how to integrate them? Should it be a contracting out mode or a strategic purchasing mode? So all those questions were not yet answered. So we thought that, okay, if we want to do strategic purchasing of this abundant private sector, do we have a service package, a costed service package, and how strategic purchasing can be done? And are there private provided chains? Because individual private providers, there will be thousands of providers. So for any government, city administration, it's practically impossible to have all those thousands of contracts in place. So can we have chains? Can we have aggregators? So that was the focus of the PEHEL project, which basically tried to see if we can organize the private primary healthcare market in the urban areas and present to the government as a strategic purchasing platform. Side by side, USAID also launched this TCI, the Challenge Initiative for Healthy Cities, which was involving the city administration in trying to understand what are the urban health challenges and what we can do about it. So after that, then we come to the SAMAGRA project, where basically we are trying to find out what is new, what is this unfinished agenda. So I won't go through this slide. Dr. Rakesh already presented this. I'll just touch upon some of the questions, and as the academic community, some of you might be actually interested, because these are the questions we need to be answered once this SAMAGRA project ends. As a USAID point of contact, I would be very happy if we are able to answer at least 60 to 80% of these questions. So you heard about from Dr. Ajit, who leads the technical hub. So there are a few questions that we want to explore within that technical hub. And that is, the first one is how to provide integrated services. And when we talk of integration, it is integration at the service delivery level, at the community level, at the monitoring level, every level. So how do we integrate services? How do you integrate wellness with healthcare? So basically, we are talking about stress management, anger management, yoga, blood sugar, hypertension. How do we really integrate all these into a wellness component of the healthcare? How to integrate comorbidities in treatment protocols and disease control programs? What tailor-made services and packages are needed? How to factor in environmental factors, and how to adapt disease surveillance for different types of urban localities. So there would be like low-income neighborhoods, construction sites, maybe transport hubs, commercial zones. So there are very different nature of these hubs within the urban areas. So how do we do a disease surveillance and outbreak management in these situations? So these are some of the questions that we would like to explore under the technical hub of SAMAGRA project. The other hub under the SAMAGRA project is the operations hub that Dr. Sainath leads. And there the questions that we would really love to explore is how to reach out to the beneficiaries. Like we have household approach in most of the primary healthcare programs, but can we have an alternative like the workplace approach? Because when we talk of urban, it's basically the workplace, which is more dominant than really the households. So household versus workplace approach, can there be some model around that? How to reach out to populations in peri-urban areas, which are neither urban nor rural, so it's nobody's baby. So how do we reach out to them, especially the outside the municipal boundaries and within the city and industrial development authorities? How to reach out to them? How to tap into social and professional networks for healthcare messaging and disease surveillance, whether it is clubs, associations, WhatsApp groups, platforms like Ola, Uber, Urban Clap, Swiggy. So there are so many things, the new age platforms that are coming up. So can we really use this beyond the traditional approach of those street theaters and IPC? So can we approach other communication materials or communication platforms also? How to integrate public and private clinics, pharmacies and diagnostic centers, either through say a e-pharmacy approach or a health aggregator approach. So these are some of the models that we would like to explore. And lastly, as Suma was presenting about the innovations, so under the innovations hub, some of the questions that we would really love to explore are what are the technology-based models to increase the reach of healthcare, reduce the out-of-pocket expenditure? Are there models for strategic purchasing and pay-for-resist mechanism, whether an impact bond or social success network notes or other kind of pay-for-resist mechanism? Can we have community-based models or community-based care models, not only where the community receives care, but are actively involved in case management? So can we have these community-based models to sustain and improve service uptake over a period of time? So those are some of the questions that we would like to have. And maybe going forward, if we can find some kind of a partnership where we can explore these questions, I think beyond project implementation, this is what really will satisfy us as USAID. So I'll just stop there. Thank you. Over to you, Dr. Yonet.
Gautam, thank you. That was excellent. The call to action is always so critical. And the questions that you have articulated here don't only resonate in the SAMAGRA context, as you say, but more broadly in the global and other context. So academic colleagues in this meeting, you've heard the call to action. There's lots of food for thought and action here. Thank you, Gautam. I would like to go to our last presenter, Dr. Shrikant Reddy with Urban Health 360. Who will talk a little bit about how we're trying to respond to some of this call to action. Dr. Shrikant. I think you're
So-
mute. Okay, there you
Oh,
are.
is it? Okay. Okay. Good morning, everyone. This is Dr. Shrikant Reddy. Thanks, Dr. Unit, for giving me this opportunity to speak about the urban health divide and the work of Urban Health 360. And thanks for the Manchester University for hosting this Public Health Week. So good morning, everyone, and good afternoon and good evening. And thanks to the previous speakers who have extensively detailed about the urban health situation in India and globally, and at the SAMAGRA project in detail. So my presentation is not about the SAMAGRA project as such, but it is to give you a brief about the work of Urban Health 360, the newly founded global organization works in the space of urban health, but also works with the SAMAGRA project. So as we all know that we are, just a second, I'm just shifting it. So we are witnessing a rapid urbanization all across in different geographic parts of the world, which is raising social, economic, and public health inequities and systemic challenges overall. As we all know that by 2050, 70% of world's population is expected to be in cities, and 90% of urban population growth will be in lower and middle income countries, particularly in Africa and Asia. And so there is also an estimations showing that the urban slum dwellers are expected to reach 2 billion by 2030. So as I said, so the Africa and Asia is the hotspots of urbanization in the next few years. So there is an expected annual urban population growth, high annual population growth in the region, as you can see in this slide. So the sub-Saharan Africa and then Asian parts are highly, where we can see a rapid urban population growth, that means annual growth. So which can be up to 4.8 to 6.4% in some countries in sub-Saharan Africa. So the urbanization, the primary drivers and the impacts, as we all know, the drivers of urbanizations are natural growth, which is a natural phenomenon, and then the migration patterns and rural transformations. So for example, in India, so every minute between 25 and 30 people migrate from urban areas from rural areas to urban areas. And the impacts of urbanization, so it's both ways, like it's positive impacts as well as negative impacts. So we do have an educational advantages, employment advantages, and healthcare access and all those things in urban locations. For example, in India, 75% of India's current health infrastructure can be found in cities. So on the other hand, the impacts of urbanization in negative terms, so it has multiple impacts on land and biodiversity, urban housing inequalities, urban poverty and service amenities provisions, climate and disasters. All these things have some kind of impact on the urban health outcomes. So the urban health and the sustainable developmental goals. So as we all know that we're in the era of, in the decade of sustainable developmental agenda, and then achieving those goals by 2030. So, and the urban health is a crucial component or crucial area of work for achieving urban health sustainable development agenda by 2030. So as we can see, so there are at least 48 global targets out of 160 SDG targets that are relevant to urban health. This shows the significance of urban health in SDG agenda. So, and that too, as we're referring to urban health, so it's mostly the health area. So SDG 3 is one area where we can see the dominance and discourse. And then we also have a dedicated goal for the SDG 11, which talks about sustainable cities. So that is where we can see a larger concentration of urban health targets in the SDGs. So there is a urban health divide. So the challenging process of translating urban health into practice has created barriers towards implementing urban health initiatives. and difficulty in linking urban health to SDG targets and outcomes. So this is what we see, or we call this gap between the science of urban health and the application of urban health in communities as the urban health divide. So that is what, as an organization, Urban Health 360 believes in and thinks about or reflects about in the context of urban health divide. And also, there is a significant gap in health status between rich and poor in many cities, especially in the global south, constraining the better urban health outcomes, which is also called as urban health divide to some extent. So as an organization, what we do and who we are, so we are a purpose-driven global organization focused on urban health of urban population across the world. It's a multidisciplinary thinkers passionate about health of the urban population. We focused on bridging the urban health divide, the gap between the science of urban health and the application of urban health in communities. So our mission is to engage poor urban communities in global south and working with them at an individual level, family and systemic level, and community level, and overall at the systemic level. So what we do, so we work with the communities, the poorer communities in the urban locations, so for the betterment of urban health indicators or urban health outcomes. So we believe that the poor urban communities are strengthened when their members are healthier, and then when they have information and tools and support to change their own lives. And then that is how we want to introduce the new ideas or thought processes that we have learned in the practice side and the theoretical side into the community settings. And we primarily wanted to target the health aspects of in the urban communities, because we believe that by working in health of the urban population, so that will have a positive impact on other sectors. So that is why we focus on health and also focusing on other areas of work. So as an organization, our approach is to enhance the practice in communities, I mean the urban health urban communities, and drives changes to the best possible and best practices, and take actions, some kind of action research, and to advocate with the society and civil society advocacy, and then the public policy advocacy, those kinds of things, and also influence the perspectives, both policies and practices and best practices among the stakeholders in the communities where we work. So this is the model that we follow, the collaborative community action model. So our applied urban health, which is exemplified by our collaborative community action model. So this has basically we intend to first we assess the situations in the by working with the communities in the urban locations, urban settings, and then we replicate models and action for changes, learning and feedback, and engagement and mobilization. It's a cyclical and iterative process. So that's the collaborative model that we work with. And we use this collaborative model by actively engaging with our action partners on the ground. So the primary areas of our work, our focal areas of work, include the understanding the health dynamics, population dynamics, and health infrastructure issues, governance for health systems, environmental equity and food security in the urban settings, or urban communities where we work. So the intent is to generate the data narratives and stories to highlight these 6 focus areas in urban communities in Global South. So at the moment since it's a newly founded organization, so at the moment we started our work in Nigeria. So specifically working with the Opoji community and Ekpoji communities in the Edo state of Nigeria, and then also working with the SAMAGRA project in India. And we are hoping to expand our work as Urban Health 360's work, and testing our models or our collaborative models to the secondary cities, particularly in multiple other countries in the Global South moving forward. So these are some of the our founding partners and collaborators like EVIDA for Women's Economic Imperative, CUHDD and action partners, Ebony State University in Nigeria, and then Eminence in Bangladesh, Precisions and Manchester University, and then we're also working with the UN Habitat as our the global organization partner. We're hoping to expand and then extend the collaborations and explore new partnerships in the countries where we intend to work in the future. So thanks. This is just to give you a sense of what Urban Health 360, the organization, how we are going to work with urban communities with regards to urban health. So thank you.
Thank you, Dr. Shrikant. And that brings our presentations to a close. Thank you all so much. I would like to say that we really, I see this roundtable as the first of many. And four major things presented themselves today. First, we heard that urban health truly is a microcosm of global health. We heard that health systems strengthening social determinants and urban governance are key to sustaining the focus on urban populations and urban poor populations as we go through this demographic transition across the globe of significant groups of people moving into cities, large and mid-sized cities, looking for opportunities and having an impact on those geographic areas. We also heard the importance of what I heard in the discussion of the city-to-city learning platform, the importance of South-South learning. Dr. Shrikant looked at the different aspects around the globe, whether it's Latin America, Africa, etc., Europe, what's happening in the urban spaces. The similarities are great, and the opportunities, particularly in the global South, where urbanization is happening most radically indeed too, and the need is greatest. There's this, SAMAGRA presents this amazing opportunity for South learning. So I'm looking forward to seeing the results of the city-to-city learning activity that's being engaged. And lastly, with the call to action, and Gautam so beautifully articulated those three key question areas, and the importance of investments of our global partners and responding to the questions that need to be explored, in the continued encouragement and resource support to answer these questions are so critical. And Gautam, I'm happy to see that USAID is leading on this with other partners. And organizations, emerging organization and existing organizations like Urban Health 360, as Dr. Shrikant articulated, that are responding to these calls for action. So I think this is a very important time as academics, as practitioners, as thinkers in this space around the global urban health as a microcosm of global health, linking it to this last decade, responding to 2030, the Sustainable Development Goals, the diagram that Dr. Shrikant showed with urban health in the middle of all the SDGs. And of course, as we respond to shocks like COVID, recognizing that COVID is one of the many shocks we will be experiencing in the next decade or two. And as thinkers in this space, we play a very important role in responding to all of this. So I thank you for the amazing presentations. This is a very, very opportune time to be discussing this, looking to SAMAGRA as a signal, as a flagship for helping the rest of the world understand how to respond to challenges and opportunities around urban health. So thank you very much. I know we're very short on time now. We've had a lot of good discussions in the chat. Thank you. And so, I will close the session at this point, asking for the last 2 minutes, any last major thoughts from our panelists and presenters, and any unresolved questions that somebody in the audience has that we should pay attention to. Yes, Dr. Rakesh.
Dr. Yana, thank you so much for everybody's time and bringing SAMAGRA in the center stage of urban health, especially for the global south. I just want to make one point, and very emphatically, is that COVID has also presented us with an opportunity, and I think now every government will try to bring in a sharper focus on urban health. So this is an opportunity if we can really sort of demonstrate SAMAGRA. So this is going to be a flagship initiative, and this can become a sort of, you can say that, not only for India country office, but for other countries, especially in the global south. So I'm seeing SAMAGRA as an opportunity, especially in the wake of COVID, in the backdrop of COVID. And I'm sure we can take this as with USAID's guidance further.
Yes,
thank you.
Yes, and thank you for that. And I'm delighted that I am able to work with you, Dr. Rakesh, on these issues. And I say to the audience, look forward for more roundtables like this on SAMAGRA. The next time you hear from SAMAGRA, I know that there will be many outcomes and results that this amazing and distinguished team will report. So thanks again. Thank you all, and enjoy the rest of the conference.